Okay, here now is acute coronary syndromes. There are three acute coronary syndromes. They are unstable angina, NSTEMI, and STEMI. NSTEMI is non-ST elevation myocardial infarction, and STEMI is ST elevation myocardial infarction. The reason why there are three is when we see these patients, so let's say we have three. We have Fofana, Lurgine, and Unique, for instance, coming to the ER, all of them have chest pain. They're clutching their chest, they're short of breath. Their symptoms are exactly the same. So let's say Miss Fofana has unstable angina. Sophia has NSTEMI, then Unique has STEMI. We cannot tell their symptoms apart. They all look the same. Okay, that's why we call them acute coronary syndromes. Is that understood? Okay. The only way that we differentiate the three is we need an EKG in order to determine whether there is NSTEMI. NSTEMI will be reflected as ST depression, whereas STEMI obviously will be ST elevation. With angina, unstable angina, yes, there may be some ST T wave changes as well. However, the second diagnostic test we need is the troponin. Unstable angina may have some ST elevation, but there is no troponin rise, meaning the troponin will be negative. Unstable angina means, yes, there was occlusion of the coronary artery, one or more. However, it did not result in death of any myocardial tissue. Is that understood? Okay, meaning, yes, for a brief period, the patient had severe ischemia, enough to cause chest pain. However, did it kill any tissue? No tissues died, meaning, was the obstruction permanent? No, it was a temporary obstruction. Okay, so the patient obviously had symptoms other than angina pectoris. Patient maybe had, Ms. Fofana had chest pain at rest, took nitroglycerin, nothing happened. So hers was unstable angina. For Sophia, yes, she had the same. She had chest pain. However, her EKG showed ST depression, not ST elevation, and her troponin was also positive. Whereas Unique had chest pain, she also has positive troponin, plus her EKG shows ST elevation. Among the three, yes, we will take care of all three. We will send Fofana to the cath lab as well, but not today. Maybe tomorrow or even outpatient. Okay, meaning, yes, you have a serious CAD. We will do echo. We will do we can even do a diagnostic cardiac cath, okay, to show your arteries, but we don't need to really do anything nothing urgent, okay? But we'll take care of you. We'll fix that because it may happen again. And the next time, maybe a heart attack. Next time, maybe an NSTEMI. Next time, maybe a STEMI. For Sophia, yes, Sophia, you had a heart attack. But Sophia's heart attack, because it's ST depression, means her the death of her myocardium is not ongoing anymore. Okay. So for a moment, yes, she had some myocardial tissue death, but it stopped now. Right? So Sophia's MI looks like this and STEMI. We also call this a subendocardial MI, meaning, yes, something died. That's why her troponin levels rose. She has positive troponin, this troponin elevation. Part of her myocardium died, but nothing we can do about that. It already died. But right now, there's no further killing. Does that make sense? Yes, she had a heart attack, but is it still ongoing? Not anymore. It stopped, right? So it's the blood flow was restored. Okay, so nothing really we can do with Sophia. Okay, we'll do your cardiac cath, but not right now also because it's too late. It died. Okay, a portion of your myocardium died. So we'll fix you later. Okay, maybe tomorrow morning or maybe in 6 hours or 8 hours. Unique, however, hers is transmural. Right. So here, the whole thickness of her myocardium died and it's still ongoing. It's still being killed. So this can expand. Okay, so therefore, do we need to treat her? She needs to go to the cath lab right now. Okay, so we'll call the team. Hey, prepare cath lab. Call everybody in. We need to open her up right now. Does that make sense? Okay, so that's the difference between the three. So NSTEMI, you have ST depression here, and then STEMI, you have ST elevation plus an abnormal Q wave, a really big dip in the Q wave, or T wave inversion. Okay, so those are the EKG changes found in unique. Okay, so she has the most serious, so she's priority. And then we'll bring Sophia maybe in the morning. Okay, so Sophia, you'll be NPO, okay? But we'll do you tomorrow. Miriam, probably will do you. Are you available Monday? Okay, we'll schedule you Monday. Okay. Meanwhile, you'll be taking aspirin, Plavix. All of them, all three will be on aspirin, Plavix, nitroglycerin. When we schedule it, yes. Yeah, you have to be NPO. And since you're diabetic also, so don't take your metformin, okay? Before the procedure. All right. So we'll take care of unique only today. Does that make sense? All right. So that's why until we get two things, EKG and cardiac enzymes, we cannot tell the three diagnoses apart. All three will look exactly the same. Does that make sense? Okay, so that's why we call it acute coronary syndrome. And however, can Miriam also become NSTEMI? Yes. Or it becomes STEMI? Yes. Yes, so that's why she'll be monitored. Okay, so we'll monitor Miriam, look at your EKG, that we will be on a continuous cardiac monitoring. And then also we'll do serial cardiac enzymes, just like the other two. But we won't take you to the cath lab today. All right. Yeah.
You just mentioned the metformin that I don't have to take my metformin because I'm going for the surgery, so I have to hold my medication.
Yeah, you'll be placed on insulin.
Yeah, because of the
IV dye.
acidosis.
No, the IV dye that we'll be using for the cath lab. Okay. So here for unstable angina, yes, she suffered a ruptured plaque. There was a clot, but then was it there permanently? No, there's no absolute 100% occlusion. Okay, so for some reason the clot was dislodged maybe, okay, and then blood flow was restored. Right? So she's lucky. But can her situation change? Yes, it may become an MI, so we'll still take care of her. Right? But we'll to lessen the likelihood that you'll have an MI, we'll put you on aspirin, Plavix. Okay, give you beta blockers. All right, so that list we had earlier. That makes sense. Okay, those medications. So just like stroke, time is muscle. So that's why in Unique's case, we need to take her to the cath lab because for every second, every minute that passes by, more myocardial cells are dying. Okay, so she may not survive. So we need to take her to the cath lab right now. So in America, look at this. After every 40 seconds, an American will have a heart attack.
Wow.
That's how many cases we have. So within 10 minutes of arrival, what do we need to do again? ECG and draw what? Okay, cardiac enzymes. Okay. As far as clinical manifestations, it's really no different from what we saw in angina. Okay, so same manifestations. However, some patients may have they're definitely symptomatic already. Blood pressure is already low. Okay, indicating they could be going into cardiogenic shock. And because Miriam's condition can change, so that's why all three are called acute coronary syndrome. Yeah. In fact, a heart attack patient may have another heart attack after the current one. So they can have multiple heart attacks.
We're talking about cardiac enzymes, right?
Mhm.
Enzymes, right? What would BMT be among?
Yes, that's but it's not really a cardiac enzyme. That just indicates we need to draw BNP because to determine is the patient in heart failure. Because a heart attack, can that cause heart failure? Yes. So in that case, if the heart attack caused the heart failure, then do we treat the heart failure at the same time? So we don't treat the heart failure?
Yes, we do.
Screw the heart failure? We treat the heart failure. So we give furosemide, blood pressure medication, same exact thing. So most patients having a heart attack are in heart failure, especially STEMI. Okay, STEMI patients are in heart failure already. Okay, as described again, we need to obtain ECG within 10 minutes of arrival. Usually there's an ECG already in the ambulance, but let's say the patient did not arrive by ambulance, then therefore we still need an EKG. Plus the doctor may want to repeat the ECG upon arrival as well, just so we get documentation.
I think that's one is lovely.
No, I mean, we'll use it as a support the diagnosis, but we still get our own. As already mentioned, the patient with MI will have heart failure. So that's why in chart 23-6, you will see manifestations of heart failure here. So on top of the acute coronary syndromes, the patient is also manifesting heart failure manifestations. So patients short of breath, having chest pain. If it's left side heart failure, the patient may also present with pulmonary edema. Okay. And then again, all the manifestations we saw in NUR 241 under heart failure. So these are the other accompanying symptoms. We, again, no different, right, from what we saw in angina pectoris. So there's nausea, indigestion, vomiting, pale, cool, clammy skin. What happens to urine output, by the way? Decreased urinary output, okay, oliguria. Again, indicating sympathetic nervous system stimulation, which we discussed thoroughly under shock. And just like in shock, so because cardiac output suffers here, so there will be changes in the mental status. And of course, the feeling of impending doom. Not mentioned here is, yes, even though here in the GI, it says nausea, indigestion, and vomiting, some patients will also have incontinence. Okay, so it may complicate things because now you're dealing with the heart attack, plus then you're smelling the BM at the same time. One thing we need to keep in mind is, let's go to the troponin. Let me show you the period of troponin rise. It's not in your textbook, but let me just show you. So the horizontal axis you're looking at here are days. Okay, this is not hours. This is day 1, day 2, day 3, all the way to day 9, 10. And this is the level of the troponin right here on the vertical axis. So as you can see, troponin stays elevated. All right. So when it peaks, varies whether or not the patient reached the cath lab or not. So of course, if the patient, what does a peak mean, by the way? Highest point. So how do you identify the peak? When will you see a peak, by the way? Just like in COVID, remember Governor Cuomo had daily briefings during COVID, right? He showed us the numbers. So why were they always talking about the peak?
Not the highest number.
Because it goes up to the same.
Okay, because you never see a peak unless it starts to go down. So is a peak good? Yes or no? Yes, it's very good. When we see a peak, that means it started going down already. Okay, so when do you want it to peak? Soon or later? We want it to peak as soon as possible. So the peak time will vary, like I said. So if Miss Copeland reached the ER in 2 hours versus if she reached it within 45 minutes, when will the peak be? If she reached it in 45 minutes versus 2 hours, which of these two will have an earlier peak? Why? Because we were able to restore perfusion. We got her down to the cath lab right away, put the catheter in, inflated the balloon, restored blood flow. So she will peak sooner. Okay. So here, instead of peaking, look at this. When does this peak? This one, this example. This is now over 1.5 days, right? Or maybe 1.25 days. Okay, so but definitely it's over 24 hours. However, if she reached the hospital within 45 minutes or less, will it peak before 24 hours?
Yes.
Definitely. It will probably peak in 12 hours or less. Right? So that definitely is better, correct? Okay. But look at the level though. Whether or not she receives perfusion, will the troponin drop right away? Will the troponin disappear? No, in fact, it stays elevated. See, this is 0 here. It's still positive up to several days, up to more than a week. All right. Now, this is absolutely expected. All right, because the dead cells, the dead myocardial cells, continue to release it. But as long as there's no new dead myocardial tissue, the levels will start going steadily down. So we don't need to actually keep drawing troponin up to the 7th day, because is it really necessary? No, because as long as you see the peak and let's say you draw 2 more and the pattern is the same, it's going down, plus the patient's symptoms are subsiding, meaning the patient has no more chest pain, is it really necessary to keep drawing troponin? you're wasting money, you're wasting time. So leave it. Okay, so we know it's going down. Plus, the patient is now symptom-free. Okay, so her blood pressure is good, heart sounds look good. There are no, well, PVCs, premature ventricular contractions, are expected. Okay, that's also expected after an MI, because of course some tissues died, right? So those tissues, of course, become irritable, and then will send signals randomly. So that will result in PVCs. Okay. So will she get beta blockers? Yes. Please keep her on beta blockers. Okay, after a heart attack. Any question on cardiac enzymes? All right. So these are the ECG changes again. So inverted T wave and or an abnormal Q, ST elevation plus T wave inversion. So here's the abnormal Q wave. Okay, so those are the ST T wave changes after acute coronary syndrome. So here for Miriam, unstable angina, definitely some just ST wave changes, but are they permanent? No, ST wave changes go back to baseline. And then does she have any positive troponin?
Yeah.
Unstable angina?
No, not.
No, because she did not have an infarction. So her troponin will be negative. Okay. And then STEMI, of course, shows the ECG changes, ST T wave changes, ST elevation, and then T wave inversion plus positive troponins. Here for NSTEMI, again, who is it? Sophia will have positive troponins, but however, her ST changes will be ST depression. Okay. Was there damage to her myocardium? Yes, that's why troponins were positive. Okay. But is it still ongoing? No more. Echo again will be necessary in order to measure what damage did the acute coronary syndrome do. We'll do echo on all three of them. Of course, who will have the worst ejection fraction between the three? Okay, it will be uniques. Sorry, unique. Okay, we already discussed the biomarkers. Now, among all three, because there will be three drawn here, we have we can draw troponin C, but in practice, most hospitals just draw troponins I and T because they are the most specific to cardiac muscle. The problem with CK, this one, is yes, these are present in cardiac muscles, but they're also present in skeletal muscles as well. So let's say the patient did have cardiac arrest during the MI, and then the staff performed chest compression, so that can raise the CK level. Okay, so any skeletal muscle injury can also cause CK to rise. Unlike troponin, wherein this is not seen in skeletal muscles. Okay, so a rise in troponin only means injury to where? Cardiac muscles only, because only cardiac muscles release troponin. Then myoglobin, this is also drawn. The myoglobin helps diagnose, but the level really is going to be significant as far as whether or not the patient will have some kidney injury. Okay. So we have algorithms to follow. So if we suspect acute MI or acute coronary syndrome, so 911, again, ECG within 10 minutes, as well as lab drawn within 10 minutes. And then this is what we do. So for the acronym, it's MONA, morphine, oxygen, nitro, and aspirin, right? But in practice, it's actually either ONMA or ONAM. Okay, so oxygen, nitro, and then morphine, aspirin. So either Onma or Onam. You can also give aspirin before morphine,
Okay.
right? And then followed by beta blockers, and then um the clopidogrel. Now, heparin is necessary when with acute MI, because can the patient have another MI?
Yeah.
Yes, remember, we haven't fixed the coronary arteries yet. We still have to take them to the cath lab. So therefore, there will be heparin infusing, okay, to prevent that. This will ensure no further clots formation, no further heart attacks. And statin, the dose usually is started high. We give them the highest dose for the statin is 80 milligrams, 80. So we give 80 milligrams of atorvastatin, and then we'll decide on the dose. The doctor will adjust the dose depending on the patient's cholesterol level. Then it'll be either 10, 20, depending on their cholesterol and their risk factors as well, whether they smoke, but that's the doctor's decision. And if the patient qualifies for reperfusion therapy, which definitely Unique needs PCI. PCI is the cath lab, percutaneous coronary intervention. So that's the balloon, okay, catheter, balloon, and then open the artery. And then they may or may not leave a stent. Same thing also for Sophia. Sophia will also need the PCI, but do we have to do it right now? No, later. Okay, later.
Would the PCS stay forever?
No, PCI is a procedure, meaning the stent.
Mhm.
Yeah, of course, when we leave a stent, then the stent stays there.
Oh, okay.
But stents can be clogged again, so we may have to remove the stent and replace it. Because sometimes they get clogged again. And when these patients are discharged, obviously these ones here are only given in the hospital, right? But make sure when they go home, what medications are they going home with? Tell me. After a heart attack or after any acute coronary syndrome.
Aspirin?
Aspirin. What else? Aspirin enough?
Nitro?
Clopidogrel, right? Aspirin, clopidogrel. Usually it's always dual antiplatelet therapy. Unless the patient has history of bleeding, the doctor may say, okay, aspirin only. But otherwise, the patient will be on two, aspirin and clopidogrel. What else? Beta blockers? Okay, beta blockers. Statin, very good. Nitro as needed. Again, anticoagulant is only during the acute episode unless the patient has a fib or a flutter. Okay. But just heart attack, only the ones we mentioned. And then, of course, the patient will be, a beta blocker is not mentioned here, but the patient will be on beta blockers for life.
For life?
Yeah, clopidogrel, aspirin for life. These are lifelong. But of course, this is only during the acute episode. I mean, you're not going to go home carrying around an IV pump, okay? No. You'll be on pills. Okay, let's go to your responsibilities. Okay. So we're not expected to work in the cath lab after graduation. So NCLEX will not ask you about what your duties are there. So, and questions will just be on how you prepare. Because let's say especially in the case of Sophia and Miriam, because they're the ones that are going to be sent and you have time to prepare. Not much for Unique. Unique, you won't even have to touch anything. So for Carl Shapiro next week, all you get to do, because it will take a few minutes for the cath lab team to set up the cath lab. So all you're doing is just hanging the heparin and the nitro Okay, so that's all you can do. And monitor the patient, give metoprolol as needed, and then send her over, right? For Sophia and Miriam, we do have time. We have plenty of time to prepare them for the cath lab. Unlike before, though, wherein we had our access is the femoral artery. That was preferred because it was the largest, right? So we were using the femoral artery. Now and not anymore. The last 10 years, it's now been the radial artery, just the arm, okay, just the forearm artery right here on the wrist. So this improved policy or protocol has resulted in shorter hospital stays, meaning Unique could go home tomorrow. Okay, she could be back to work tomorrow, right? Granting we got her in the, let's say she got there within 30 minutes maybe or 45 minutes. So her recovery time is very short. Because there's no need for bed rest. We were able to open her up. So there's really no activity restriction. Okay, just make sure the access site had the pressure dressing, no bleeding there. She can go home the next day. Unlike before when we had the femoral, so many complications because the access site usually bleeds, we got a hematoma, so plus the patient's on bed rest, and when you put them on bed rest, then they get blood clots again, DVTs. So it's much better today. Plus, when we had the femoral access, that means you had to clip their hair in the groin because sometimes some people have hair, pubic hair in the all the way to the groin, right? So you had to clip that area. Okay, no shaving though. Okay, we do not shave. We clip the hair
Meaning you
for access.
like you
Use a razor to clip the hair.
An electric shave.
Electric razor, yeah.
Oh, okay, yeah.
Yeah.
Okay.
Because we don't shave.
Right.
Okay. So no more shaving. I mean, unless you have a really hairy arm. I mean, who has hair here? No, right? The hair is in this part, right? Yeah. So it's not needed anymore.
Okay, where do they go, like, some people don't have, you can't really see their veins, but they're ready for them.
Yeah, it's either the radial or the femoral.
Oh,
Yeah.
okay.
But I mean, there's no really no, I've not seen on the right here on your radial artery.
Oh, no, you're saying on this side of the.
No, this is the radial artery.
No.
No. You okay? Okay, we'll shave you. No problem. I'll do it myself. All right, so let's go to the standard. Okay, so how long should we get you in there? As soon as possible. So the standard is less than 60. Used to be less than 90, but of course, which one's better, 60 or 90? 60. And all cath lab or PCI capable hospitals can do it in 60 minutes or less. Okay, that's how efficient our care is now. So door to balloon time is 60 minutes. That's quite fast, right? So when you hit the ER, so in less than an hour, you're already in the cath lab and we already got the catheter in. We already saw the blockage. We already opened it. Okay, under 60 minutes. For patients who decided to have a heart attack in the middle of nowhere near any PCI capable hospital. So let's say Unique was in the Amazon jungle. The closest hospital to her was some little hospital with no cath lab. Do we have time to transport her? No. As long as she meets criteria, she will receive a thrombolytic instead. A thrombolytic is a clot buster. It's a drug that will dissolve blood clots. It's a dangerous drug, obviously. It will dissolve any clots. So number one side effect will be hemorrhage. But we'll look at the criteria. Okay. So thrombolytics can be given within 30 minutes of symptom onset. So as long as she reaches the hospital within 30 minutes from the onset of chest pain, then they have no cath lab. We assessed her. She has no contraindications. She has no bleeding disorder. She has no brain tumor. She didn't have stroke in the last 3 months. She's menstruation is okay. Okay, menstruation is not a contraindication for thrombolytic. Only bleeding disorder, right? But menstruation is okay.
So if they have a thrombolytic medication, right?
Mhm.
Why do they put patients on Coumadin for the rest of their life?
I don't know which patient you're referring to, but warfarin is usually prescribed for AFib or aflutter or after mechanical valve replacement. Those are or if let's say you had a PE, a multiple PE history. So which one are you talking about?
Well, I'm trying to find out
Because that's not routine. Not every hospital, heart attack patient will be on anticoagulant. I told you that.
Uh-huh.
So only who gets anticoagulants? AFib, aflutter,
Okay.
history of
But
PE or DVT.
Yeah,
But heart
DVT
attack is not an indication for lifelong anticoagulation.
You-
Lifelong antiplatelet, yes.
You mentioned DVT, right?
Yeah.
So the DVT, I remember Parenting was saying that the DVT that people got, they won't be on thrombolytic. They will be on maybe rivaroxaban or
Yeah. Who said we're gonna give thrombolytics for DVT? We don't.
but is the
Because
blood
it's not
clot,
worth
right?
it. The clot is not worth, dissolving because remember, our body dissolves clots naturally. Okay, so we don't throw around thrombolytic. What did I say? This drug is very,
You say powerful.
very dangerous. Okay, very dangerous. So the patient has to meet certain strict criteria before they can receive it. Okay, it's a dangerous drug. Okay, don't get me wrong. I know I said it casually, but
All right.
okay, but it's dangerous, right? We'll get to the indications and contraindications shortly. So here, chart 23-8. So unique can receive a thrombolytic, which is alteplase, if she meets these. So we said within 30 minutes, right, from symptom onset. And her chest pain has been lasting for more than 20 minutes, unrelieved by nitro, ST elevation, again, less than 12 hours. Okay. These are absolute contraindications. Patient unique cannot receive alteplase if she has any of the following: active bleeding, again, except menstruation. Menstruation is safe. So if she has any hemophilia, or I mentioned she had a stroke, any of these abnormal blood vessels, either aneurysm or an AVM, recent trauma or surgery, uncontrolled hypertension, and not mentioned here, a brain tumor is also a absolute contraindication, and pregnancy. And because of the danger of bleeding, so once a patient receives a thrombolytic, these are your bleeding precautions. Any questions?
Can I ask you a question?
The what?
So-
Oh.
721.
Chart 23-8, page 741. We'll skip cardiac rehab. We're not testing cardiac rehab. All right, let's go to our responsibilities now. Okay, so for nursing interventions, we said MONA, correct? But what's the actual order? ONMA or ONAM, okay? So same thing next week for Carl Shapiro. In what order do you implement them? ONMA or ONAM. So oxygen, then nitro, morphine, or aspirin. Activity will definitely be bed rest. Reducing anxiety, you may or may not use drugs here. The caution, if you prefer to use drugs, is the blood pressure. Remember, these patients receiving nitro and morphine and beta blockers. So all of these will drop the heart rate and the blood pressure. Okay, so be careful if you need to give any benzos, any CNS depressants. Yeah, no, Valium. All right, let's go now to your responsibilities. So here is PCI. This is the gold standard. If possible, if the patient's hospital that they were brought to is capable, use PCI instead of thrombolytics. It's much safer. So here's the description. So through a small artery, a balloon tip catheter is inserted. And with the guidance of IV contrast, it will be placed up into the coronary arteries. And then the balloon will be inflated, okay, at the tip of the catheter to open the atherosclerotic plaque by compressing it. So if your blood vessel is blocked, so we'll put the catheter in, inflate it, it will flatten the atherosclerotic plaque, opening the artery. If needed, the doctor will leave a mesh or a stent, okay, to keep the blood vessel open, the artery open. Here's teaching here for discharge after a heart attack. Please read that on your own. It's about the same, modifying the metabolic syndrome, losing weight, stop smoking. For exercise, by the way, the activity, the basis for the resumption of their usual activities of daily living and including sexual activity is based on if they can climb 2 flights of stairs or walk 1 block with no shortness of breath. What are they again? If they can walk 1 block or climb 2 flights of stairs without dyspnea, without symptoms, then they can resume normal activity. It's not really a period. Used to be it was standard that okay, after 6 weeks you can resume, but some patients were able to achieve the target in less than 6 weeks, and sometimes also after 6 weeks or more than 6 weeks. So the basis was based on activity tolerance. So as long as the patient can walk 1 block, no shortness of breath, no dyspnea, climb 2 flights of stairs, no dyspnea, then you go ahead. You can resume your normal activities, including sexual activity. Because some patients will, of course, be afraid, right? I mean, it's scary. They survived a heart attack. So will they be cautious or apprehensive about returning to activity? Yeah, it's scary. Plus, not good with the partner, right? The partner wants to resume sex, but then the patient's afraid. Oh, I have a heart attack again. Okay, so it's reassuring, right? That the relationship is healthy. That way, yeah, you reassure them that yeah, you can tolerate that. You can tolerate sexual activity. Okay, and here's your teaching. please disregard, look at the first, do you agree with the first bullet? Call 911 if pain is not relieved in 15 minutes by taking 3 nitroglycerins. Do you need to
No.
wait? No, because if you wait, then you lose time, right?
Yeah.
Remember, time is muscle. So when do you call 911? After the first one, not after 3. Because what is angina again? Angina responds to nitroglycerin and rest. So after 1, call. And then, of course, after 5 minutes, take a second and then a third. Okay, and then call the provider with these. That means what's happening? What is the patient developing? What are these signs and symptoms of?
Hyperconditioning, cardiac arrest, angina, respiratory.
Isn't that heart failure? That's heart failure. Okay. Remember, they're at risk for heart failure, okay, after a heart attack. Okay. Now, I won't do this because this is the description of the procedure. I mean, again, we're not doing this. Okay, the doctor's doing this. Even the cath lab nurses, they're just there, they're not doing this. It's the doctor that's performing the procedure. All right. So we'll skip. I mean, it's nice to know. As already mentioned, a stent can be applied. Okay, they can leave a stent, meaning after they inflate the balloon, they may put a stent there to make sure it's a metal stent. Okay, wire stent. That way it stays open. It will not, collapse. So that's what a stent is. It's a metal mesh, okay, like a tiny little wire. Okay, wire mesh. These are, of course, very small because the coronary arteries are tiny, right? So these meshes are really small. So here's the description. So that's what it looks like. Okay, so balloon, inflate, flattens, and then here's the stent that's going to be left behind. That's the wire or the metal mesh.
So can atherosclerosis also develop in the veins?
It can develop in any blood vessel. Yeah, but mostly arteries. Okay, let's go to complications now. Can they have another heart attack? Yes, so clots can form even during the PCI procedure. Patient can also have bleeding, especially if, let's say, because remember, this patient did receive multiple blood thinners, right? So they received antiplatelets, plus they were also receiving heparin. So bleeding can be a complication. Remember, this is decreased cardiac output, correct? So can there be kidney injury? Pre-renal, intra, or post? Only pre-renal?
Not intra.
It can also be intra from the dye, right? Okay, so pre-renal and intrarenal AKI can be possible. Okay, so and then site-specific bleeding would be hematoma on the site. And then after the procedure, if the patient again has radial artery, I can't say the same for femoral. Femoral, the patient has to stay. But if it's radial, patient can be here. No complications. They go home the same day. Okay. So in the case of Miriam, if she decides, okay, yeah, let's do the PCI. So she comes in Monday and then she can go home at the end of the day. Okay. Same thing also for Sophia. But since Unique had a heart attack, we may have to keep her, right? So these are the advanced vascular closure device and Angioseal. So this is what you'll see on the patient's access site. Okay, they may look like ordinary dressings, but they're pretty tough. Okay, very effective compression. Only if we have a femoral access. A femstop, let me show you what it looks like. It's a yellow, I mean, usually yellow. And it has a band here. So you see this like there's a blood like a blood pressure inflator. This one. Okay. So how it works is you wrap this around the leg. Okay, so this is somebody's femoral artery. Okay. So this is clear or yellow. So you put that there. Then you wrap the strap around the patient's hip like this. Then when you compress this will pull the strap. This will pull the strap because this one will start compressing. So we compress until we have to make sure that there is still pedal pulse because we don't want to compress it too much that it will obliterate the circulation. Okay, so just enough pressure to that we still have a pedal pulse, but we're putting pressure because otherwise you'll be putting manual pressure here with your hand for who knows how long. Okay, so this one is more effective. You put that is way better than sandbags. Although sandbags can fall, right? So a femstop would be very effective. Plus, pain free. You don't have to put pressure yourself. Plus, it's way more effective.
Would the heart still be pumping blood while we do this? While the doctors perform this?
Say again.
Would the heart still be pumping blood while the doctors do this procedure?
Which procedure?
The one that you just showed us.
The femstop?
Yeah.
No, femstop is only to prevent bleeding.
Oh, I'm talking about PCI.
Yeah, we are under PCI, but this is now post-procedure. We're under post-procedure.
That person came to mind when we were discussing the PCI. So
Oh yeah, absolutely. We're not stopping the heart. That's a different story. That's now under bypass
okay.
grafting. Okay, that's on the next page. So any question on post-procedure? Okay, so usually the patient, there's no, again, radial access, no need to restrict activity. Patient can walk, activity is tolerated, and then sent home either the same day or the next day. But if it's femoral, then the patient has to be kept. Bed rest after femoral access is usually 6 to 8 hours. Just to make sure there's no bleeding. If the patient cannot undergo PCI, which means these are the criteria. The angina cannot be controlled with medication or PCI. The patient has too many coronary arteries involved. It's usually 3 or more coronary arteries. We can't stent that many. It's not worth it. So it's better to do a bypass. Prevention of MI, and then after an unsuccessful PCI, then we'll have CABG. So CABG is coronary artery bypass grafting. Let me show you the picture. So these are the grafts that can be used. We can either use the patient's leg veins, either saphenous vein, that's usually the most common. How do we harvest the vein? It's good now. We can do endovascular harvesting now, meaning before, during my time, that was before 2010, the doctors will make an incision from the groin all the way here to harvest the vein, meaning they'll open the patient's leg, take out the vein. Now it's just 2 little incisions, maybe 1 inch, 1.5 inch incision, one here, and then pull the leg, the leg vein out from these 2. Okay, so they just cut the vein, and then pull it out. Okay, so it's or here, cut, pull it out. Okay, so at least we have smaller incisions and less complications whenever that's the case. We prefer an artery, of course, over a vein, because which one is more durable? An artery. However, not all patients will qualify with a arterial bypass graft. If it's arterial, we use the mammary artery, which is already connected to the aorta. So we don't have to connect anything to the aorta. It's already connected to the aorta. All we do is take it out of the breast muscle and put it into the coronary artery. Okay? But of course, because it's an artery, there's more bleeding if that was the procedure. Okay, because of course, when you take out an artery, more bleeding, right? So more blood loss. Whereas if it's a vein, less blood loss. That's why we call it a bypass, and then there's a bypass machine involved, because as you indicated, if the heart is beating, can you sew the graft properly? I mean, the heart keeps moving and then you're playing with a needle and suture. No. So the best protocol is stop the heart from beating, use a artificial heart-lung machine to circulate the blood, okay, during the procedure, and then put it back, and then leave pacemaker wires, of course, because you need the pacemaker to reactivate the heart. Okay. So let's go again. We're not involved here. The doctor does all these. Okay, so that's the mammary artery. So see, it's already connected to the aorta. So this is the mammary artery. But if it's a vein, then it will be sewed here. So you will attach the vein to the base of the aorta and then put it into wherever you need to put it. Okay, so that's vein, and then that's the mammary artery. So we have nothing there. Our pre-op will just be education and then shower the patient. The shower can be literally a shower, or if the patient can't get out of bed, then it will be a bath. We bathe them with chlorhexidine soap. You know chlorhexidine, right? No, the chlorhexidine we use for central lines. Okay. That antiseptic comes in a soap. Okay, a liquid soap. Smells good too. Hibiclens. Have you heard of Hibiclens? It's sold. It's over the counter. Pharmacy. Yeah, it smells good, right? Are you using it? Why? It's expensive. Okay, so here's the procedure. If you want to know, they induce hypothermia and attach them to a heart-lung machine. Okay, let's go straight to our job. So our responsibility afterwards is here. As I said, pre-op, education, and then shower the patient. There may be 2 showers. Some cardiologists insist on shower the night before and then shower the morning of. Okay, antiseptic shower, antiseptic soap shower twice. Okay. Yeah, again, if the patient can't get out, then you'll have to do wipes, okay? A bath, a bird bath. So here are complications after the surgery. And let's go to your post-op. Okay, post-op management. So we have an extensive wound here. So you have a long sternal incision. There's really nothing to care about it because it's glued. Okay, so they sutured it with a wire to close the the sternum, but then the skin will just be glued, right? There's really no sutures. But expect tubes coming out. So here are the tubes that you have to monitor. So you've got there are 3 tubes here because these 2 mediastinal tubes here are attached to, remember chest tubes, right? Okay, so the same chest drainage system. This is attached, of course, inside the pericardium to drain blood, because otherwise, if the blood is not drained, what will happen? What will develop? Cardiac tamponade. Okay, there'll be tamponade. So you, of course, you have to drain that. So your responsibility is to make sure these two tubes are draining. Okay, because can it clot? Yes, it can clot, and then your job is, of course, to notify the physician. The third one is the they have three here, but it's usually just two. And then you have the third one is usually the pacemaker wire. Okay, because the patient is still attached to a pacemaker here, because until the heart recovers, the SA node will not fire normally. So you'll have bad dysrhythmias. So until then, the patient will have a external pacemaker. So that's your most important job. And of course, pain management. Give the patient lots of pain medicine. Okay, we'll give it around the clock and also as needed. These are very expensive procedures, so these rooms are wonderful. It's like living in Waldorf Astoria. Okay, it's a big suite, very nice furniture, very nice window views. This will be a very good place to work. You get paid very well. Plus, it's 1-to-1. 1:1 patient ratio. Best job in the world. That's it.
Thank you.